It's that time of the morning now where we cross over to our TNA with Peter and Dora. The guest in the hot seat is Dr. Aaron Motsoaledi, the health minister himself. They are in Fourways to discuss the state of healthcare in South Africa during the 20 years of democracy. Peter, it's over to you.
Leanne, thank you very much indeed, and a very warm welcome to you. Yes, we're in Fourways, just north of Johannesburg. And this is the scene for the latest in the series of New Age business briefings brought to you by the SABC and today sponsored by Telkom. And we're talking health, and this is an area, of course, that affects every single citizen. At one point in your life, you will engage with the health system, either when you're a baby, getting immunizations, or when you fall ill. And the question is, what is the state of our healthcare system? What's been the story of the past 20 years? What's been the legacy of the ruling party that's been in charge of our healthcare system for the past 20 years? And what does the future look like? What are some of the innovations that have been brought to the fore? Well, the man in the hot seat today, who's in conversation with us and you at home, don't forget you can join in and ask questions via Twitter at SABC Morning, at Morning Live SABC, or hashtag TNA Biz Brief, and we'll get live responses from you from the Minister. And so with that, it's a great pleasure to welcome the Minister of Health, Dr. Aaron Motsoaledi. Thank you very much for joining us, and welcome. Always a pleasure to have you on the program.
Thank you, Peter.
All right, well, let's start with this big question. 20 years down the line, 20 years of democracy, great promises in 1994. How well have you done in fulfilling those promises 2014?
Well, we think we have done a lot, Peter, but we are the first to argue that the journey is still long. Remember, here we were reversing many years, not just a decade, many decades. You can even count it in centuries, if you so wish. One of the things that South Africans might have forgotten is that 20 years ago, we had 14 different healthcare systems in this country, with 14 different laws and 14 different acts and 14 different sets of health workers, etc. We had to start by amalgamating them, make one healthcare system that speaks to the rest of South Africa. The second thing we did was access. People might even forgotten that there were hospitals here in this country, which were very highly equipped in terms of resources, both financial and human, and other commodities, in which other race groups were not allowed even to go nearer the gate. I'm not talking about private hospitals, I'm talking about public hospitals, which were used exclusively by certain race groups. We had to open that access. Thirdly, there were parts of the country where people never even had a clinic or any health service whatsoever. We have to put them up. If you look back, you will find that out of the 4,000 health facilities, I'm talking here of clinics, hospitals, and health centers, there are 4,000 in the country. 40% of those were created after democracy in the past 20 years. So that's how much we have achieved in that regard.
All right, but there have been some challenges along the way.
Of course, there have been serious challenges.
Some mistakes made as well. Which ones would you say, okay, we hold up our hand, we could have done better in these areas?
Well, I'll think of 3 areas which are quite problematic and for which we have already developed plans, which I believe, yes, we could have done better. The first, of course, was our early approach to HIV and AIDS. I'm sure everybody knows about that. It's legendary. But fortunately, we have now turned the corner. We have corrected that, as you know, more than we ever imagined. The world now regards us as a model country in terms of that. The other area where things went wrong was the assumption that anybody can just enter a hospital and become a CEO or a manager. Anybody from any background, as long as they've got some form of education, they can run a health facility. When the issue of a hospital being run by a superintendent, who's the most senior doctor in the hospital, was removed in favor of CEOs and anybody could be a CEO, you are aware that we are reversing that. It happened in the past decade and it was very bad. The third one is maintenance of our health facilities. Now, we have changed the system of how our healthcare facilities are maintained. We are putting up a very strong engineering unit in the department. And as I'm speaking now, it has completed a lot of work, Peter. We now know work is going to begin in a way that is amazing because they've been planning. A lot of planning has gone in on how our health facilities has been sort of not maintained over a long period of time. So those are the areas that I regard as quite problematic.
Okay.
And of course, I can't forget the issue of human resources. It will always be a problem, not only with us. South Africans believe it's only their problem. It's a global phenomenon. The shortage of healthcare professionals.
Some of these issues.
Yes, there is a shortage of 4 million healthcare professionals around the whole world. Only that in sub-Saharan Africa, to which we belong, it has been declared a critical area, a crisis area, not critical area in terms of healthcare professionals by the World Health Organization. So those are the areas that are still very problematic.
All right, we'll unpack a lot of those areas as the conversation unfolds, but let's fast forward to current day and some of the issues that have come up and also some of the announcements that you've made recently that some might consider game changers. But let's start with this perceived war that you have, with the pharmaceutical companies, that you are working tirelessly against them. They've got patents that they want to protect, and you're working hard to destroy these. Tell us, what is the state of play here?
Peter, I've got no war with pharmaceutical companies. Absolutely not. They are at war with the public, not me. Yeah. Because yes, what they are going to do is not going to destroy me, but it will destroy the public. It will destroy people. You yourself have just said, at one stage or the other, you have to have contact with the healthcare system. Actually, human beings enter this world through the healthcare system, and a lot depart through the healthcare system. So your entry into the world is through the healthcare system, and your departure is within the healthcare system. So anybody that touches it, why am I saying they are at war? Look, this so-called war about patents, where people believe I want to stop patents, it's not even a policy that was determined by me. It's a policy determined by the Minister of Trade and Industry, my colleague, Minister Rob Davis. He put up a policy for public comment about software, agriculture, arts and culture, sports, and pharmaceuticals. The others, nobody says something about anything about them. They pick up, and it's not all pharmaceutical companies, those who affiliate with this document, public engagement affairs, they pick up pharmaceuticals, and they say, no, there's going to be no change here, no reform here. What reforms were we looking for? We're looking for reforms not in favor of the Minister of Health, in favor of the public, to make available affordable drugs. Because the healthcare system cannot run without affordable drugs.
All right, but these companies, I mean, the argument they put forward is, A, we have to spend billions in research and bringing these drugs, and we need to make a profit from them. We're not altruistic to a point that we just give away things. So isn't that the reason for having patents, to protect?
Of course it is. So what's wrong with that? Nobody is going to abolish that. That has not even been determined by me. That was determined in 1995 by the World Trade Organization, WTO. It was established in 1995. It's one of the world UN agencies, obviously, the World Trade Organization. After being established, they declared that patents must be protected for a period of 20 years. If you innovate something, you must be given a patent for that as your intellectual property. And for 20 years, nobody must touch that. We are not going to do away with that. That policy document is not saying we must abolish that. Patents will still be protected for 20 years. But the same WTO went on to say, in order to protect the public, there must be flexibilities that protect the public, especially in public health. And those flexibilities, they call them TRIPS, trade-related intellectual property rights. And they went on to say, countries must incorporate that in their policies and their laws. That's what this new policy wants to do. Since 1995, South Africa never, in a way that is adequate, incorporated TRIPS flexibilities from WTO into this. What are the flexibilities? They are aware, Peter, that you can have an intellectual property. That makes a medicine worth thousands of rands. And you have got 1 million people dying. They need that medicine. What does a country do? Where is the choice? Shouldn't there be a balance? That balance was struck between the World Intellectual Property Organization and the World Health Organization. That we need to hit a balance here between health and your intellectual property. Now, your intellectual property for 20 years, we're not touching it. We're not going to take it away. There's no policy that says that in the country.
So I'm trying to understand.
What is the new policy?
A, what is the new policy? And also B, how far on either side are we going? Because we've got, on the one hand, I guess, where patents are protected, overprotected maybe. And then on the other, we've got countries like India that somehow are able to deliver drugs even much cheaper than we are in South Africa.
Yes. All that India did was to take the TRIPS flexibilities of the World Trade Organization and incorporate them into their policies. That's all they did. That's all we wanted to do. Take the flexibilities, they are already there. For instance, one of the things that we are fighting with, we are not fighting these 20 years. Let me tell you what some companies do. When they realize that that 20 years is about to expire, to allow anybody to produce generic medicines, they just go and tweak one molecule in that drug, one molecule, and apply for a new patent as a new drug. So that 20 years will never come to an end, which was given not by us, by the World Trade Organization. They just tweak that. The second thing, we need an office that examines these applications. Many countries, including India, have got them. We've got a situation here in South Africa that patents are not examined, Peter. It's a foregone conclusion. You just apply in whatever way you get it. 40% of patents which have been rejected in America and Europe, they found their way into South Africa and they are granted. That is why in this public affairs engagement document where they wanted to fight, they say South Africa is ground zero. If things are allowed to change here, then they are going to spread all over the developed world. And that's why I got so angry, because they are saying they are going to keep us back not to develop when others are developing.
All right, we've got a few pharmaceutical companies here. I'm going to ask them for comment during the course of this conversation. NHI, let's just unpack that a little bit, because again, medical aid schemes have got a thought on it. Doctors in private sector have a thought on it. And you have your thoughts on how this NHI works. The guys at home want to understand how this whole system is going to work, and how is it a question of choosing between public health, private health? Are medical aids going to be affected? Just give us your thoughts on how you see NHI and some of the concerns that doctors in private practice and medical aids have been raising.
It will be wrong, Peter, to mention only those people who have got, say they are the only ones who have consent. Everybody has got a say about this. And not only everybody in South Africa, this is becoming a world phenomenon. That's why the World Organization called it universal health coverage. We call it NHI. We decided to call it NHI in South Africa because that's what we wanted to follow. That's what we have termed it. But the World Organization called it universal health coverage. In the United States, as you know, it's called Obamacare. But the actual official term is Affordable Health Care Act. They got it in a country like Mexico. It's called Seguro Popular, a popular scheme for everybody. And you know that Britain has been having it from as far back as 1948. It's called NHS. So it's not that we are doing something that is unique, that has never happened about the world. What is it all about? It is about healthcare financing, Peter. It's about healthcare financing. All that we are saying is financing healthcare in the world over decades, including in our own countries, even worse. Financing healthcare has always been in favor of the rich. It has always been a punishment to poor people. You have just mentioned medical aid. Yes, I've got a medical aid. It helps me and my family. But it's a big punishment to those who are poor. Yes, because they cannot be part of it.
So who's going to pay for this?
Who pays for all government programs? Who pays for all societal problems? Who pays for education in this country? Who pays for roads? Who pays for hospitals?
So it'll be taxpayer.
Of course, everything is paid for by taxpayers in a particular country.
So I'm going to pay medical aid on the one hand, and then on top of that, you're going to ask me to pay for the NHI as well.
Well, if you so wish, if that's your choice, it's not mine. All we are saying is, yes, it's going to be your choice. Yeah. It's not going to be mine. All we are saying is, if we get a new healthcare financing system, that is universalist. But by the way, Peter, you said it's a choice between public and private. Yeah. It's not. These things are in the Constitution. I don't know why people try to ignore them. Go to Section 27 of the Constitution of the Republic of South Africa, which was accepted by all political parties and everybody, which has been celebrated around the whole world. You will find that they have written there that healthcare is a right, and that the state must do everything within its available resources to make sure that this right is realized. It can't be a right for the few, Peter. It can't be a right for you, for me, because I'm employed. Because that's what medical aids are. You have got the right to eat. If you are employed, you have got a title, you have got a name, you have got a salary. If you don't have all those things, you are not in. What about the Constitution, which says everybody?
Okay, that's fair enough. My issue then, I guess, becomes, I don't mind paying you, giving you the money to provide this public health care, but you must provide health care. You must provide the hospitals, and people in the rural areas are saying that we don't have these hospitals, we don't have these clinics. So are we sure, A, that the money that we give you is going to provide this health care that you're promising?
Yeah, absolutely. You actually have it spot on. People believe NHI is about money only. The preparations we are making goes far, far beyond that, Peter. If you come to my office, I'll give you volumes of novels of preparation. And actually, that question was answered not only by me, it was answered for the whole Africa by the director of the World Health Organization in the African region. In July 2012, he called Dr. Louis Sambo, by the way. He called ministers of health and ministers of finance, not only health, to Tunisia to discuss this issue. And he said the first thrust that Africa must do to be able to enter into this field of universal health coverage, which we call NHI in South Africa. He said the first thing we must do is to make the public healthcare system efficient. And he said in order to make it efficient, we need to look into its infrastructure. And he said by infrastructure, I actually quote him. He said by infrastructure, I mean staffing, human beings. I mean buildings. I mean health technologies. I mean utilities like water, electricity, waste management, telecommunication, transport. All those things, if you go to Europe, you'll take them for granted. In Africa, it's a problem. All those things, if you look at them, and I want to repeat them, the staffing, the building, the health technologies and other commodities, the utilities like just getting water running very well uninterrupted, electricity, waste management, transport, telecommunication. If you look at all our plans for NHI, we've got that. If you come to my office, in the 11 pilot districts, I can actually tell you in graphic detail, even in terms of cost, what we need to do for each and every clinic and hospital.
But will Treasury give you the money? You've been allocated 145 billion rand. Is that enough to do what you're planning to do?
There's never enough money anywhere in the world. I've never heard about that concept of money ever being enough. It has never happened. Because otherwise there wouldn't have been the study of economics. We'll always be having enough money for anything we need. but within the resources that the country can afford, within the present economic climate, what has been given by Treasury to us, we can start working on it. And we've already even defined it. If you look at the manifesto of the ruling party, we said in the 11 pilot districts alone, we're going to build 43 new hospitals as part of preparing for NHI, 216 new clinics, and 876 health facilities are going to be refurbished and renovated. When you mean refurbished, you don't just mean painting and putting a new roof. You mean that including even the equipment and the maintenance program. And we have got plans, even drawn up to the last cent for that. We have even produced a document of what we call an ideal clinic, and we're already working on 10 clinics to run like that. What is an ideal clinic in South Africa? What is a clinic which will get satisfied if I go to? A clinic to which I can send my own child or yours. At the moment, those of us who are well-to-do, there are health facilities we don't even dream about entering. That's why when I was sick, I went for an operation in Steve Biko. It became headlines. That's a scandal. Why should it be headlines when I'm in a particular hospital? That the minister went to this hospital rather than the other. There's no country that should be run like that. We should be proud to enter all our health facilities. So starting with a clinic under NHI, what type of clinic? We have actually mapped it, and I can show you what we actually mean. And there are a few of these 10 where we are studying, where I'll show you the features. For instance, we start with administration. What should the administration of that clinic look like? Starting with the signage when you enter from the main road. That's how far we start. How are the pharmaceuticals run in that clinic? How is the security run? What type of staffing? What commodities are there? If you go to Arangua, I'll show you one of the clinics. It must have a generator standby.
Okay.
Yes, it must have a 10,000-liter
We're
drum.
going to have to take a quick commercial break, but I want to unpack that and get the questions from the floor and from Twitter, and they've been coming in quite a bit. You talked about staffing. They're talking about the way they're treated by nurses, these hospitals, the queues, and so on and so forth. So these are great plans, but the challenge often with these plans is implementation. So we're going to chat a little bit about that, and you can answer some of these questions. All of that coming up after this break. Be part of this conversation. It affects you.